For our first session this morning, we have the privilege of spending an hour with someone who has spent decades seeing LHON patients in our clinic, doing research, writing over 450 scholarly publications, lecturing around the world, and consulting with companies and organizations interested in doing LHON research. The LHON community has benefited greatly from the depth and breadth of her work, and we're fortunate to have Dr. Nancy Newman as an LHON advocate. An abbreviated review of her academic credentials includes graduating summa cum laude from Princeton University, attending medical school at Harvard University, doing her internship and residency at Mass General, and her fellowship at Mass Eye and Ear. Dr. Newman has been at Emory Eye Center in Atlanta since 1989, winning many awards for teaching excellence and training 65 fellows who have become the next generation of neuro-ophthalmologists. One of those fellows is someone who's spoken at prior LHON conferences, Dr. Patrick Uiman of the UK. Most recently, Dr. Newman was asked by the UMDF to join the Scientific and Medical Advisory Board. From a personal perspective, I first encountered LHON in late 2008 when my oldest son, Jeremy, was affected. I connected with people on the old LHON Yahoo group, and many people mentioned they'd visited Dr. Nancy Newman at Emory, but I was on the West Coast, so we were seeing Dr. Alfredo Sadoun. I spent a lot of time scouring the internet looking for information about LHON. One day, a few months after our LHON journey had begun, I read the author's bio on an LHON article and suddenly realized the author, Dr. Nancy Newman, was a college classmate. I made contact, and she gave me her perspectives on LHON, its past, present, and potential future. We've continued the conversation ever since, and for the next hour, we'll discuss LHON here with all of you. Dr. Newman, first of all, I want to say thank you very publicly and quite sincerely for all you've done for me personally, as I've dealt with the sudden and profound impact LHON has had on myself and my family. And on behalf of the LHON community, thank you for all of your years of research, education, and clinical care. We're so fortunate you're an LHON advocate, which leads to my first question. How did you get involved with LHON in the first place? Did it find you, as it did me, or did you make a choice getting so deeply involved with LHON?
Well, I'd love to tell you that I had this vision and it was the thing that I was going to go after, and it was all planned. But as often is the case with these kind of things, as things find you guys, I was a Northeast snob in Boston. I thought I'd always be a Northeast snob in Boston, and I was recruited to Emory University actually in 1988, came in 89, because they didn't have a neuro-ophthalmologist at all, and I was offered a very, very senior position as neuro-ophthalmologist on faculty, and so I came, despite the fact that I'd never been to Atlanta. I'd never been to the Atlanta airport. I'd never lived south of New Jersey. And I thought, well, I'd just come for 2 years and then go back to Boston. I've been there 28 years. I don't look that old, right? But I'll tell you something, she really doesn't look very old. And I know her birthday. So for those of you, you probably all know this, but a neuro-ophthalmologist basically deals with the brain side of vision. And the optic nerve is actually not even a nerve, it's a tract. It's a central nervous system white matter tract. And so neuro-ophthalmologists own the optic nerve. That's our favorite piece of tissue. We also do eye movements and stuff like that, but we're optic nerve specialists. And so I arrived in Atlanta at Emory, didn't really know anybody there except the chair who had recruited me. And guess who across the street had just published in the New England Journal of Medicine the first point mutation in mitochondrial DNA to be associated with a human disease, and that human disease was Leber's hereditary optic neuropathy. And his name was Doug Wallace. And Doug Wallace began the whole journey of mitochondrial DNA abnormalities being the cause of human disease, and Leber's hereditary optic neuropathy was his main entry into this. And so we reached across the road and it started a collaboration of a basic scientist who needed a clinician to validate and get patients, figure out whether this was clinically relevant, and a clinician who needed a basic scientist. And we have really collaborated ever since. He left Emory probably 10 or 15 years later, but that didn't stop things. And then by then I had a clinical database, a clinical specialty, and I've been very, very privileged and fortunate to see several of you in this room, but to see many Labor's patients from all over the world. And you could say, in many ways, I took advantage of you guys. I built my career on your disease. And that, you know, that when I spent 4 hours with y'all last night, listen to me, I said y'all. 28 years, it finally did something. It's okay, for McCarthy back there, I'm gonna talk. So anyway, I've really built my career on a disorder, and in some ways, meeting with you all last night, I was ashamed in some ways because I've benefited for years because of something horrible that's happened to you. On the other hand, it's allowed me to have a motivation, and I have never, ever regretted a minute. You know, everybody's job has garbage to it, right? I have never, ever regretted working on this disorder and trying to both help patients as well as promote research that indeed, as a secondary effect, has made my career for me. But it's quite the community. And I will say the connection with Lissa has completely changed everything. You have the most amazing advocate here, but we're not going to get into that. So I answered my question.
Thank you. Okay. So summarizing 28 years of effort to just a few minutes is an unfair request, but could you share with us some of the history of LHON research and clinical care over the years as you've lived it, some of the things we now take for granted but were actually new findings at the time?
Sure. So some of you are older and were affected at quite a young age, and so you probably remember those days better than I do. So before molecular diagnosis, so that would include my training, Leber's hereditary optic neuropathy was a rare disease that supposedly only affected men, and you could tell that someone had Leber's by looking the back of their eyes when they had the acute onset of vision loss and looking for a certain finding of the front of the optic nerve that was swelling, but it wasn't real swelling, and it had some funky vessels, and only the most astute clinicians could pick that up. And if you didn't have that, you didn't have Leber's, and you had some other funky form of optic neuritis that was affecting men. I mean, that was basically it. If you had a family history, that made it easier, but people were really unsure about that too. They thought, well, it must be sex-linked because it involved men more than women, but there was this weird way it was being transmitted and nobody could figure it out. And then Doug Wallace came along, and you realize he had studied mitochondrial DNA for 20 years before he published the finding on LHON. And I wouldn't say he was ridiculed, but he was certainly not in the forefront of science. It was hard for him to get grants. He did a lot of anthropologic work with mitochondrial DNA, you know, tracing maternal lineages and figuring out who was the first woman on Earth, you know, finding Eve, right? And, but he wasn't, people didn't really think of mitochondrial DNA as anything other than vestigial, like an appendix, that it was a piece, it hung out in mitochondria because mitochondria back in evolution were bacteria, and bacteria had these circular DNA, and so they never really thought of it as anything that could cause human disease, that an abnormality could cause human disease. So so that was the pre, and so it was people like Van Sennis in the Netherlands putting together these large pedigrees of people with labors and writing about them, but the inheritance wasn't truly known. Eeva Koskelainen in Finland was doing all this. And then Doug found that first mutation, the 11778 mutation, which is also called the Wallace mutation for him. And it changed everything. It changed everything, you know, and then everyone was, all of a sudden, mitochondrial DNA abnormalities became very she. Anita Harding in London was discovering things like NARP and all these other point mutations in mitochondrial DNA that could cause disease, deletions and things like that. That's for downstairs. And so people who would probably have gone into other fields all of a sudden decided to go into mitochondrial disease and mitochondrial genetics. And then it was a big flurry for the next 5 to 10 years. Oh, I've got a new mutation, and I've got a new mutation. And some mutations turned out were just polymorphisms, meaning they just reflected the haplotype of the mitochondrial DNA. Whereas others, if you go through the rigorous control findings to look, were truly pathologic point mutations. And so after about 5 or 6 years, the 3 primary mutations that account for about 90% of labors, it was thought 95, but we're finding more and more nowadays, so it's probably about 90%. So the 11778 for worldwide, about 60%, but 90% in Asia, the 3460 and the 14484. So then we had those 3 mutations that could be commercially tested for. But before that, the collaboration with Doug allowed me now to go have everybody tested and find the 11778. And so that was 1990, the year of 1990. I worked with Doug and Marie Lott, and we found hundreds of patients who were positive for 11778, and that's the big article in 1991, which started to describe the characteristics of LHON when it was molecularly defined. And it went out of the box for what we thought was LHON. So number 1, you didn't have to have a family history. It could happen as a singleton case. Number 2, it could affect women. Number 3, although most people with the 11778 had terrible vision, we had a few who didn't, and we had a few who got better. And the few who got better were under the age of 20 and especially under the age of 10 when they were affected. So we began to see these new things, and then finally 50% of patients, even when looked at when they are just having their vision loss acutely, do not have that classic fundus appearance, the appearance of the optic nerve, which would in the old days have made them not labors because they didn't have this finding. And we found that in over 50% of patients, their optic nerve looked normal at the time of diagnosis, and therefore that's why they were being misdiagnosed as retrobulbar optic neuritis. So having molecular confirmation changed everything. And then there was this flurry of all these new mutations, and people started to write from very limited numbers of cases the characteristics of the other mutations and why they were different than the 11778. But over time it played out they really weren't. The presentation of all 3 of the primary mutations was exactly the same. The difference was in spontaneous recovery, specifically for the 14484, with up to 70% of patients down the road having a potential for spontaneous recovery. And so that's really sort of, and now we've gotten so far because we've gone finally beyond diagnosis. We've gone beyond, which was extremely important. So it was diagnosis, then descriptive characteristics clinically, prognosis, what's going to happen. So the longer we have people who are molecularly confirmed, the longer experience we have to know what's going to happen with them. And then we get to treatment. And the last 5 years or so have been the beginnings of that. And I wish I could be up here and say we have the penicillin for labors. We don't yet. I don't know if we will. I'm hopeful within 10 years we will. I'm going to say it now because I may forget to say it later, but this way I'll say it twice. You guys, right, you have this opportunity to be part of history. If there is a chance to be part of a clinical trial, take it, especially given that every clinical trial since the Rhodos trial that I'm aware of has not relied on true placebo controls. We have placebo eyes, but we have not really had placebo controls, which means that you get the drug in some form. So I really strongly suggest, because there are luckily so few of you, even though there seems so many here, that if you have an opportunity to participate in a trial that you qualify for, that you do.
Thank you. I know for a long time, you've been a cheerleader and advocate for LHON research. Could you share with us why such a rare disease generates so much interest and why you've described LHON as an ideal laboratory for testing treatment efficacy?
Okay, so again, this is the reality check for you all out there being human beings that I had a great deal of fun talking to last night, and the reality check for the fact that every time, and I think a few in this room can attest to this, every time I have a patient and a family in my room, I do not leave until they are finished asking their questions. It doesn't matter that my RVUs drop and I don't get paid very well, but no, that's a salary. But I get pushed to see, like every other doctor in the world right now, as many patients as possible in a day. And I like to believe that, to hell with that. I take my time with my patients. And I'm going to get real excited about you and your disease when I'm talking about it right now, and it may sound like I'm objectifying you, you know, that you're not people. But it is amazing what you have, your disorder. There is not another human disease in which you can be so certain that another body part will be affected within a certain amount of time. You know, you can predict what's going to happen with a cancer, you can predict what's going to happen with a degenerative disease, but Leber's is the only disorder in which when one eye is affected, in 97% of cases, the second eye will be involved within a year, usually within less time than that, which means that you can use one eye as a test and the other eye as a control, because you've got this intra-patient comparison. The second aspect of Leber's, which makes it extraordinary, is that there is a window in about 50% of cases where you do have this time before the second eye is clinically involved, potentially to try to stop that second eye involvement. Now, some of our research has shown that that second eye probably is subclinically involved right from the get-go, but you still have potentially this window. Unfortunately, in 50% of cases, it's either simultaneous in onset or simultaneously recognized. In other words, one eye may have gone already, but it was the non-dominant eye, so the person wasn't aware of it until the second eye went. But for those 50% where you have this recognized clinical window, it means you have a window of opportunity to stop the second eye or keep it from getting as bad. And that is unheard of in the natural history of any other disease, to such a strength that if we were able to completely stop a second eye from happening by some intervention, we'd need, 10 patients to show how remarkably effective that agent was. Whereas often in trials, you need thousands of patients in order to show an efficacy of an intervention. So that's one powerful thing about Leber's. The second powerful thing about labors as a testing is that, for the most part, you all are tremendously healthy otherwise. And you are young, and you are motivated. And so it is the ideal testing person to have in clinical trials and to be able to not worry about other aspects of a disorder. I'm going to lose count after a while. Where's my Monty Python person in the thing? You know, my third thing. Okay. Okay. So I'll say another thing that makes it an incredible laboratory for testing agents is that the eye and the ganglion cells in the retina, which are the cells that are affected in labors, are unbelievably accessible for treatment. Downstairs, they're talking about mitochondrial dysfunction that's affecting the brain and other things. You can't get things to it. But in the eye, you can give drops which diffuse back to the retina. We know that that works for glaucoma, so we know it gets there. You can stick a needle in the eye. Now, some people will go, ew, but I bet you there's some people here who are old enough that they've had needles stuck in their eye for treatments of macular degeneration, central retinal vein occlusion. It's common. It's thousands of needles in eyes every day. And so it's a safe thing. It's done all the time. And you can absolutely direct whatever agent you are interested in directly to the cell that's affected. That is unheard of in the body. We put it in the vein or through, or through the mouth and hope it gets to where it wants to go. In this case, we can give it directly. Another thing that makes it an incredible laboratory, and it was talked about a little earlier today, is that mitochondria dysfunction is really hot in medicine. Poor, Doug, 20 years until it got hot, but it's hot, and it's hot not necessarily for diseases like you have, which are point mutations in mitochondrial DNA or patients who have deletions in mitochondrial DNA. It's hot because more and more we're finding that degenerative diseases that affect millions and billions of people, like Alzheimer's, Parkinson's, that the final common pathway is via mitochondrial DNA abnormalities and mitochondrial dysfunction that are acquired with age. So you can imagine that if you could find something that stabilizes mitochondrial function using as a model a mitochondrial DNA disorder, that the applicability of that agent or intervention to these diseases that affect even so many more people and therefore can get funding and can get the pharmaceutical companies money and all that, you are crucial to the tip of the iceberg here to what potential there is for humankind and caring as well as monetary benefits. So that's another reason that labor's patients are hot. Everybody wants to test on you to find out. Apoptotic drugs, the retinal ganglion cells presumably die by apoptosis. If there are agents, we can get right to the retinal ganglion cells that stop the cell death from happening. Think about what diseases that could have applicability to, like glaucoma and macular degeneration, which have way more people affected than labors. So it's horrible to get so excited and want you in so badly, but you're wanted very badly. People come to me from companies that I have nothing necessarily to do with mitochondrial disease per se or eye diseases, and they think about labors as this amazing laboratory, this amazing model that can have meaning for well beyond the individual patient with LHON.
Thank you. So could you share some of your thoughts and experiences with LHON research efforts, some of the past, the present, and some of the possibilities for the future?
Well, I think there are a couple of companies, as you know, that are involved in trials and in treatment. The first really was Santher, and so I should tell you, I'm pretty much a consultant for every one of the companies. So I have no preference for, they're all lovely people. I've really enjoyed working with them, and so that's been said. So idebenone was probably the first to show some promise with the retrospective review by Dr. Corelli's group in Bologna, and then the randomized controlled trial done mostly in UK and Germany with Santhera's backing. The problem, of course, with that trial, as everyone knows, is that patients were included up to 5 years out, so the chance of something showing efficacy was already hobbled by that, because once you have optic nerve death, it's very hard to reverse those fibers. Subgroup analysis did suggest that there may be some benefit for patients who are in the early stages and therefore have discordant vision. So most LHON physicians and experts, and we had a consensus meeting on this. It's going to be published in the Journal of Neuro-Ophthalmology. We met together to sort of figure out what experts say and have it put somewhere for other neuro-ophthalmologists and caretakers and patients to see. Most of us do recommend at this point idebenone during at least the first year of labors, but I think even the Santhera people will agree it's not the cure, it's not the penicillin for labors, but right now that, it's been approved in the European equivalent of the FDA, and our FDA is dealing with it, kind of working on it. And so that tends to be, at least among the neuro-op experts, the standard of care right now for acute LHON outside of trials. I don't know much about the stealth trial. The nice thing about that is we're talking about eye drops instead of more invasive things. And then, of course, there are the gene therapy trials, which, as you know, are based on what is called allotopic rescue, meaning we still do not have the know-how to inject a gene into all the mitochondria in cells to go directly into the mitochondrial DNA. We do have technology for injecting the normal mitochondrial DNA gene of a patient into their nuclear DNA with a special little tag on that DNA piece that when that protein is made, the tag tells the protein to go into the mitochondria. That's called allotopic rescue. And as you know, that's gone through cell in vitro studies, rodent studies, primate studies, and has been in 3 different groups trials already now in human studies. So the Chinese group did it. Their patients, this is all for safety. It was felt to be safe. Their patients also, there's a suggestion of efficacy, but they included very young patients who might have improved otherwise, so it's a little difficult to interpret. There is John Guy's group, who is doing both safety and efficacy studies at the same time. And then there's the GenSight group that did its safety study in Paris, which showed safety, although it does cause a little bit of inflammation in the eye, which can be treated. And then there was a suggestion maybe of efficacy if done within 2 years of onset of the disorder, but the study was not constructed to show efficacy. And then ongoing, there are 2 parallel efficacy trials for patients with the 11778 who have had both eyes involved within 6 months of onset, and the other trial is between 6 months and 1 year. And I am the international coordinator, principal investigator for that trial. I am masked, so I have no idea what the results are. The 6 to 12 month trial has closed. We had the 36 patients necessary for that. The 0 to 6 month trial, I think, needs maybe 4 or 5 more people, and it also will close. The results will probably be available the beginning of 2018, with the hope that these are positive results. There is already work afoot to see about a potential bilateral injection study. So that's where I think the world is right now. Meanwhile, Santhera is doing long-term studies with idebenone. There should be things popping up all over the place, which would be the best thing ever. I know from talking to you all that even just a little bit of help seems worth the cost, the risks, the procedure, the pain in the butt of going through it all. For me, I want to see a slam dunk. I want to see something that we don't need a statistician to tell me that it works. But I don't know, and we'll see. Yeah, we'll see.
So our audience includes people with a wide range of connections to LHON, people who are recently diagnosed, people affected for a long time, male carriers, female carriers who either have children or who may have children in the future, loved ones, supporters such as dads, spouses, kids, etc. You've seen many of each in your clinic over these years. Do you have any thoughts to share with each of these groups based on your many years of experience?
I think you're going to hear from a geneticist later to tell you about who should think about being tested and all that sort of thing. Let me tell you the consensus on that first. So that was, again, part of the Santhera funded, which was really terrific, meeting that we had to try to come to consensus about a lot of things in LHON, not just treatment. And it really, if you know that a mom has a mutation, you really don't need to test the kids. Every single child will carry that mutation. Heteroplasmy doesn't happen very often in labors, and it certainly doesn't happen in that direction. You can have heteroplasmy enriched to homoplasmy, but you don't go homoplasmy to heteroplasmy. So if you have...
Can I stop you and ask you to explain those
I'm
terms?
sorry. I'm so used to everybody knowing. Okay. So each mitochondrion has like 3 to 10 circles of DNA. And then there are thousands, hundreds to thousands, depending on what the cell is, of mitochondria in a cell. And so, you know, if the cell needs more energy, it has more mitochondria. So a person's mitochondrial DNA is a reflection of not only what's in each mitochondria, but how many mitochondria in the cell and what their DNA does. And then the tissue will relate to how many cells, what percentage of their mitochondria. So if you get a point mutation in one little circle of mitochondrial DNA, or 10% or 15%, but the other 85% has the normal mitochondrial DNA, that's called heteroplasmy. That a cell or a tissue has both what we call wild type, normal mitochondrial DNA, and abnormal, mutant mitochondrial DNA. And remember, we're testing blood cells for their mitochondrial DNA content, and yet we're talking about a tissue which is the optic nerve. So one could argue maybe the mitochondrial content in the blood doesn't reflect the mitochondrial content in the optic nerve. And so you could imagine this could be really, really complicated. And not only would we have to test the blood, but we'd have to test all the different tissues in the body to know what someone's risks were for blindness. A lot of studies have shown that with labors in particular, the blood really does reflect all the rest of the tissues. Pretty much. I mean, we've done autopsy study, it pretty much does. And most people who have labors, most people who carry the labors mutation, are what we call homoplasmic, meaning the mutated DNA, it's mutated, all the mitochondrial DNA is mutated. There are, and in our first study of these in 1991, there are probably about 14% of pedigrees that we saw that had some degree of heteroplasmy in some relative. And then there's the issue of what we call a de novo mutation, which means that nobody in the family except that person who is affected has that mutation. Somehow in the egg or the zygote, something happened that made it just for that person. And so it's been suggested and proven in other diseases, not so great with labors, but to some extent, that if you have a certain amount of heteroplasmy where the mutant is below a certain percentage, like below 50% or so, that you're at less risk for expressing the vision loss than if you were homoplasmic. So people wonder, well, maybe I'm heteroplasmic, maybe my risk as a carrier is less, and so they all want to check. So that's why I'm saying if a grandma or a mom is homoplasmic, there's really no chance that the children or the maternal lineage down from that person will have heteroplasmy. So you don't really have to check. But it's certainly reasonable if someone is newly diagnosed with labors and they have a mutation, and it doesn't matter whether the mutation is homoplasmic or heteroplasmic, it is reasonable to test that person's mother. If that person's mother is homoplasmic, then you don't have to test the siblings of the person who's affected because they will be homoplasmic. So that's the first thing for kind of carriers. The second thing is, I know there's a lot of buzz. Well, the second thing is the mutation itself. So I think the big difference is the 14484. The 3460, I think the jury is still out whether you have the same risk for poor prognosis as the 11778 or not. There just are not enough people with that mutation to call it. For the 14484, there is no question that you have a better prognosis, a higher rate for spontaneous recovery, and a better ultimate visual outcome. And that's really the difference among the three mutations. For those of you who have primary mutations that are part of the 10% that are not the so-called three primary mutations, but you have a primary mutation, it's a disease-causing mutation that affects only one or a few pedigrees worldwide, there the jury's totally out because we don't have enough cases to know what your prognosis is. In general, I have found that those people do have a better prognosis. Now, as regards environmental factors, there's a lot of things out there. You can get things published in the literature pretty easily that are anecdotal case reports of triggers for labors. You know, if you look hard enough, everybody's had some head trauma. Everybody's inhaled some smoke. Everybody, and I have to tell you right up front that I am a data-driven person. I do not believe things. I should be from Missouri. I'm the show me state. I do not believe things until I have seen them scientifically proven. And so I will tell you the things that the LHON community of research, of experts, of the doctors believe for sure. Tobacco use. tobacco use is associated with an increased risk of expressing vision loss. Heavy alcohol use with an increased risk of expressing vision loss. Mild alcohol use, not shown. I heard someone go, whew. You want a glass of wine on occasion, a beer, that's, please, that's ridiculous. Until someone shows me otherwise right now, okay? Do we know in carriers? Well, yeah, because we know that those two things, before someone lost vision, if you take the people who are at risk for this disorder, there's a higher rate of people using cigarettes and heavy alcohol who convert to vision loss than those who don't. On the other hand, there are still far more people who are complete teetotalers and have never smoked a cigarette in their life who have lost vision from labors. It's not the answer, but if you're looking for things to avoid, those are probably good things to avoid anyway. There are a few medications because their mode of action we know is anti-mitochondrial DNA-like that probably trigger labors, but they're medications that you may need to be on anyway. One is ethambutol, which is used to treat tuberculosis. There are other agents to treat tuberculosis. My feeling is if you are a carrier and you have tuberculosis, you should probably use those other agents. The other group, and these are the only two groups of drugs that I believe really have been proven to have any kind of triggering effect, are the antiretroviral drugs used for HIV. I don't think you can stop being on those. So that's something that, unfortunately, I don't think we have an answer for. But their mode of action does sometimes even cause mitochondrial myopathy. So, I mean, it really is a drug that affects mitochondrial function. I'm not sure how much further to take your question. The key things I always get asked are from the carriers, or what can I do to not have this happen to me, and then there's the genetic testing question, and then these agents. Everything else is sort of personal and individual, and I know there's also, let's get the elephant in the room right out front. There's the whole guilt of being a mom who has passed this on. I don't know where this community is sitting on mitochondrial replacement therapy, the whole issue of being able to choose the fact that your child will not have your mitochondria, but that's the whole brave new world out there too. That's coming up.
Some of your LH1 patients have extraocular features, and some also have MS. Could you talk a bit about what those conditions look like so people might recognize it better if they happen to be one of those people?
Yeah. So this is really complicated, and I don't think even people like me understand it really well. There's a great deal of debate in the literature. Let me talk about the MS first. So there is a higher association of multiple sclerosis, both clinically, imaging-wise, and paraclinical, like spinal fluid content type markers, and vision loss from labors. Then you would expect to find, if you look at just the incidence of vision loss from labors and the incidence of clinical expression of MS. Now, here's the problem. There are many people at autopsy who have plaques in their brain that look like MS. So they had MS their life, but never clinically expressed it. And as you know, there are many people who carry the mitochondrial DNA point mutation that causes labors but they never have vision loss in their life. And if they're not from a known family, they wouldn't even know it, right? If you take just the susceptibility to MS, so the genetic predisposition to it, you add in who in autopsy has MS that didn't know it, you take all the clinical MS, put it all in one lump, and you take all the carriers, or at least the presumed carriers of disease-causing Leber mutations, whether they have vision loss or not, and you look at those two incidences, then the idea of having MS and Lebers together from that big pool, so the susceptible MS, the susceptible Lebers, is completely consistent with chance. Completely consistent with chance. So why is this popped up as a disease, Harding's disease? And we think it's because when you have the chance occurrence of those two big pools, that one disease will influence the other's expression. So if you're about to get an optic neuritis from MS, and you have an optic nerve that's compromised because you're a carrier for the 11778 in Lebers, then that optic neuritis won't have the typical optic neuritis of affecting you mildly and then you get better. It'll affect this optic nerve that's ready to blow, and it will trigger Leber-like vision loss. And it's probably the same the other way around. And I've termed that coincidence with influence. I think it is coincidental, but the disease probably influences each other. So that's that one. Leber's plus. When I coined the phrase, I'm not sure what I meant at the time, and it's become, in my mind, two different things, but they both get called the same. And the reason I did it this way is because we're talking about, when I coined this, we didn't know all the mutations out there, and I guess we still don't, but I think we have a pretty good idea because we can sequence the entire mitochondrial genome now. We couldn't really do that easily then. There are Leber's plus, which basically means you have a Leber's-like loss of vision from optic neuropathies, but you also have other neurologic or systemic features. And so the systemic things would be like diabetes. The neurologic things would be like dystonia. There are Leber's plus cases like that, which are due to specific other point mutations in mitochondrial DNA, like the 14459. And that goes with an encephalopathy and other things, okay? They are different diseases that, because they're mitochondrial and because the optic nerves are relying on mitochondrial, that optic neuropathy is going to be a manifestation of something screwing around with the mitochondrial DNA. They are specific genetic entities. And then you have the Leber's plus, where everybody who carries the 11778, almost everybody just has optic neuropathy. But there are cases, individual cases, where someone might have a cardiac conduction defect as well, or someone may have a peripheral neuropathy, or in rare cases may even have little lesions in their brainstem. Although now I wonder whether those things are part of this whole MS issue, or may have basal ganglia changes, which in the other mitochondrial diseases are very common. And yet all they have, we think, is the 11778 mutation, but they don't have so-called plain vanilla LHON. They've got something plus. Now, whether we find out that that's due to other secondary mutations or a different haplotype upon which the 11778 occurred, it gets very complicated. But I think the reality is there are people who, for all the world, should just have optic neuropathy, who may have other neurologic findings, which may or may not have to do with that mitochondrial DNA mutation, versus those who have definitely a different genetic makeup, a different mutation that causes sometimes also just plain Leber's, but more often a more complicated pedigree, more complicated expression of other findings systemically and neurologically.
So what I'd like to do now is get Bryce and Molly to get the microphones again and see if anyone in the audience has a question or two that you'd like to ask. And if you do, I would like you to wait until Bryce and Molly bring you one of the microphones so that we can capture the question as well as for everyone to hear it, but more importantly on the video later on when people watch it, if they couldn't hear the question, it's frustrating. So if anyone wants to raise their hand and ask a question, we've got one in the back and one in the front and one in the middle. And Molly's got one first.
Hi, thank you. I'm 38. I came down with Leber's. I think I have the 3460, and I got it when I was around 19. My brother is about 5 years older, and he does not have it. Is there any way of predicting whether he will ever get it?
The short answer is no. The longer you go, presumably the less likely. There is that bracket of age between 15 and 35 where it happens more frequently, but as you probably know, we have molecularly confirmed onset of vision loss in Leber's from as young as age 1 to as old as age 87. So there is no definitive way of predicting it. No, sir. Tell him not to smoke. I know. Most don't. Yes.
Hi. You made a statement regarding that if you can be part of a clinical trial, do it. On the theory of do no harm first, there's a concern where, well, the vision's not great, but you don't want to hurt the person by being part of a clinical trial. Can you comment on that?
Yes, and I think that's partly why, much to the disappointment of several people in this room, the clinical trials have specifically used only the 11778 mutation to date as far as the intervention clinical trials. So idebenone has used all three, but for anything that could do harm, we want to make sure first that we're using the mutation that has the most people so we could have success in recruitment, but even more so, in order to show that it has an effect, we need a disorder that reliably, unfortunately, is going to not do well, is going to have poor vision, and therefore the risk of the intervention and the cost-benefit ratio is on the side of doing something. I mean, I would have told you 15 years ago, are you kidding me, putting a needle in the eye? But I mean, it really is a safe thing, and everybody's grandma here has probably had it done to them.
Okay, thank you.
I've just got a quick two questions. One is you were talking about the heteroplasmy versus the homoplasmy, and I have a brother and a nephew affected. And is my takeaway a little bit that either my mother or my nephew's mother, my sister, should get tested to see if they are perhaps heteroplasmic and so the risks are
so
different?
For their personal risk, it is reasonable to do that. And I will yield to the geneticist later, but and it's also reasonable to do it because maybe they have siblings.
Right.
So it's just a general, if they want,
Right.
it's a general test to at least give them a feel. Yeah.
Okay. Quick question.
Yeah.
Is there, from your research, a correlation between intention tremor, which I understand can be is a brainstem lesion, and a high incidence of that in a family, and the appearance of labors?
Yeah, so that's really problematic because intention tremor is extraordinarily common, way more common than labors, and it is familial. So I think what would be very interesting if you have a family like that would be to see if there's male transmission. And that'll tell you immediately it can have absolutely nothing to do with the mitochondrial DNA problem. but intention tremor is extremely common. And most often we don't know where it comes from. You don't see lesions on an MRI. You just have it.
I wasn't very familiar with the plus expressions that you just talked about. Do these challenges show up at the same time as the vision loss, or can you have the expression of the vision loss and then later in life have these other expressions as the plus?
So if we're talking about the regular mitochondrial DNA mutations, the primary mutations, and not the ones that are genetically different, because the genetically different one, that's a whole different ballgame. These things can show up whenever they want, although there is a tendency for them to be around even before the vision loss. For these minor, and for some people they're not minor, and I apologize, but we sort of refer to them as minor neurologic issues. It's hard to tell because a lot of them have been reported. So for example, in our 1991 study, we asked people at the time that they had their vision loss, do you have anything else? And so we have these things that I suppose if we asked a regular general control population at that age, do you have these things? We might have found them in exactly the same prevalence. So I can't really answer that, and I can't answer, if it comes later, I can't even tell you whether it's related or not because we don't know. It's rare. I mean, most people, most of you out there, I mean, we all begin to attend to our symptoms a lot more. I completely disregard some numbness I have, right? But if I had a Leber's mutation, I'd be wondering, wouldn't I? So it's hard. It's really hard to know. But most patients with the primary disease-causing mutations with Leber's do not have other systemic or neurologic findings outside of what they may have just because we're human and we get old and things happen.
You had spoken about data. I know that there's many people in this room that are affected and many more. How do we collect data?
Okay.
And
So let me tell you we have a little bit of time. Let me tell you the main part of this story. And she's so humble. She doesn't even talk about it. But, you tell me if I get it right, because I don't want to be apocryphal here in all this. But Lisa approached me like many parents of Leber's patients who, are devastated. And, she has incredible resources, not just that she went to Princeton, but she's okay. She's smart, and she had a fabulous job, and she, and she says, what can I do? Can I raise you money? What would be the best? Should we try to put a foundation for and I said, the kind of money that's going to really propel this, we're talking millions and billions of dollars. That's not coming from you guys, okay? I'd love if you commit to research. It'd be terrific. I could fund a fellow, for just $10,000. But that's what I said to her, and I had said it to several other parents who didn't want to bite because it's not sexy, was if you can just gather all these disparate little groups, put together a registry so that when we have something that may work, all you have to do is push a button and we've got the 36 people we need for our trial. I said, you have no idea what that will do. No idea. And it's like hard work that doesn't seem like worth much anything, but it's huge because doctors can't do that. We have HIPAA laws and IRBs, and I cannot reach out to one of you if you have not contacted me. I can't even talk to you because we don't have a doctor-patient relationship regarding giving you medical advice or diagnosis from my office. That's against the law. And so she doesn't have to deal with HIPAA or IRB. If you guys opt in, you can give her all your private medical information that you want. And then she provides me, she puts the button, she gets the list. We tell her, if anyone's interested, contact us. And it happened. It happened. It was revolutionary. And in addition, she's changed how clinical trials work. And what you guys have done here in this community is the model that every rare disease now is trying to mimic. And in addition, she went above and beyond. She does, selfishly, the registry, that was great. But then she created a community, and she created education, and she created sources for you all. And this was going to be my ending, and it's probably a good point because I think we're about ready to end, which is there were two things. One, clinical trials, please, please. You have no idea how important, not just for you and your families, but for so many other diseases, how important this is going to be. But the second is, don't let her get hit by a bus. I know that sounds somewhat facetious, but the bottom line is this was one person's brainchild who has given up her job and this has become her life. And look at what she's created. And of course, she's got she's going to tell you it's a lot of help from a lot of you, and that's so true. But this has to perpetuate. And I don't know how it's going to perpetuate financially and how it's going to perpetuate with human resource, but it has to. And the best thing that this community can do is figure out a way to make that happen. We're going to have her for at least another 30 years. We both, we're going to be standing there with our little white bracelets. But at our 40th reunion next year, we'll be there with these white things on. But please, for those of you who are young and interested and you've got the resources, both human-wise and financial, whatever, that's your key thing here, because it all will depend on that. If we get something to try, if we don't have that registry, if we don't have that information, we're not going to be able to pursue it. Now, I would love a registry that was with real medical data, but again, it's so hard. We've tried it 3 separate occasions to go through the NIH, their rare disease thing, to get funded, to have a, but the HIPAA laws are crippling. They're just crippling. I cannot reach out to people. So please, and I think we're gonna stop here.
Sure, we'll stop here.